A very good afternoon to one and all. It gives me immense pleasure to invite all the distinguished guests, esteemed colleagues, and all the attendees who have joined us to invite you all to the Neurocritical Care Society of India's presidential oration. We celebrate today a very important thing, which is head injury. So, this oration is themed around the World Head Injury Awareness. I invite Dr. Ponea, who is the president of Neurocritical Care Society of India, to introduce the session.
Thank you, Dr. Matangi. Thank you for the introduction. On behalf of the Neurocritical Care Society of India, I welcome all the members and others for this important oration on traumatic brain injury on the occasion of World Head Injury Day. I am also extremely proud to have Dr. Kaira with us, and she has been kind enough to be here for our oration. Thank you, Dr. Kaira, for coming and coming to NCSI to deliver this oration. Thank you so much. And
thank you for the invitation.
Yeah. Over to you, Dr. Matangi. Maybe you can proceed with the proceedings here.
I now invite Dr. Saurabh Anand, who is the Secretary of Neurocritical Care Society of India, to give us an insight about the role of the society in neuroscientific research and development. Dr. Saurabh, the floor is yours.
Matangi, 1 second, Dr. Saurav is... Saurav, you can join Saurav. Yeah. Hello. Join. Yes, Dr. Saurav.
Yeah, hi. Sorry for the delay. Just in the traffic, it actually took me 2 minutes extra to join. Okay. So, where are we? I have to start?
Yes.
Yeah, you have to introduce about NCSI, please.
Yeah,
Okay.
you have to introduce
So,
NCSI, Secretary.
Okay. So, am I audible?
Yes, you proceed, please.
Oh, yeah. So, dear esteemed members of Neurocritical Care Society, good afternoon and welcome to this session. As your secretary, it's my privilege to address you today and reflect on the invaluable contributions of our society in the field of neurocritical care. This society was actually conceptualized in 2019, and the first conference was actually done in 2020. It was actually supposed to be done in April 2020, and then it was actually, because of COVID, it was done virtually in October 2020. Presently, we are close to 250 plus members and growing. Last year, we have just completed the 4th annual conference in Gurgaon, which was attended by around 400 members, 400 people actually. 250 plus members have attended, and the next conference is going to be in Chennai, which Dr. Punaya is going to do. In my role, I have witnessed, I will say, firsthand the passion and commitment of our members to enhance patient outcomes, to promote education, drive innovation in neurocritical care. Through our collaborative efforts, we have fostered a community where knowledge is shared, and I will say the compassion thrives. As a society, we are not merely passive observers of the progress. We are active agents of change. Our education initiatives like these conferences, webinar, these workshops, empower healthcare professionals. One of them is actually acute neurocare course. Empower healthcare professionals with the latest evidence-based practices and advances in neurocritical care. And with that, we are nurturing the next generation of neurocritical care providers. We ensure a legacy of excellence that will endure for years to come. And in closing, I will extend my gratitude to Dr. Kaira Roba and every member of our society for attending this session. And over to the chair. Thank you.
Thank you, Dr. Saurabh, for that encouraging words. Now it gives me great pleasure to invite Professor Uma Maheshwar Rao, whose expertise in neurocritical care is very well round. So a few words from you.
Are you able to hear me? Are
Yes,
you
sir.
able to hear me?
Yes, sir. Please proceed, sir.
Yeah. So it's a great pleasure for me to participate in this evening's presidential oration of NCSI. We have a great speaker, Dr. Shera Roba from Italy, who is leading frontline research in traumatic brain injury. I thank Dr. Ponaya and Dr. Sauravanam for this opportunity. I would like to trace the evolution of head injury management in 3 stages. In 1970s, 80s, and 90s, the emphasis was on improvement of general critical care, such as correction of hypoxia, hypotension, and stabilization of systemic physiology, like fluid and electrolyte balance, blood sugar, renal function. A great improvement has been achieved with these measures. It's in the same stage that the importance of controlling raised intracranial pressure was also appreciated. The second stage started with the publication of Brain Trauma Foundation guidelines, which laid down targets for ICP, CPP, osmotherapy, sedatives, seizure prophylaxis, etc. Some debate arose on some issues, but there was a sense of direction in the management of head injury, with which some more improvement in head injuries came about. This happened around late 90s, 1990s, and around 2010. After that, there is no major breakthrough that changed the outlook for these patients. Some technology innovations have come out, but they are not accessible to the majority of patients, like brain tissue oxygen tension, the microdialysis, etc. The Synapse ICU study published by Dr. Shera Robo seems to have brought in some clarity on some issues like ICP targets. Let's listen to what she has to say on the major developments in the last 1 decade in the management of head injury. Thank you.
Thank you, Uma sir, for those wonderful words. I would like to now invite Professor Ramesh. Sir, please give us your perspective on today's event.
No, see this. If you see in the last 1 decade, there is an explosion in the literature on neuromonitoring, and especially this neuromonitoring in application to head injury and SAH. So I feel, today's lecture is going to summarize. So these 2 things. So I am very eager to listen to Dr. Vera Rama, so who has done an extensive work in both these fields. I am also eagerly waiting for the lecture.
Thank you, sir. Now I would like to invite Dr. Anil Parekh. Sir, please grace us with your insights.
Thank you for inviting me. I'm just traveling and I wish you all the best for NSCIC. And I welcome Dr. Khet and accepting our invitation. Thank you very much.
Okay, so the highlight of today's event is the presidential oration by Dr. Kiara, a luminary in the field of neurocritical care. To introduce our esteemed orator, I am honored to invite Professor Mihir Pandya. Over to you, sir.
Very good afternoon, ladies and gentlemen. I thank the organizers, Dr. Punya and Dr. Saurabh Anand, to give me the honor to introduce the speaker today. Dr. Kiara Rova, presently working as a researcher in the RTTV Department of Surgical Science and Integrated Diagnostics, Dirigenti Medico, Anesthesia Rianimazione, IRCCS, San Martino, Genova, Italy. Previously, she has worked as consultant in neurointensive care and neurotrauma, Edinburgh Hospital, Cambridge, United Kingdom. And before that, she worked as consultant in intensive care and anesthesia, clinical lead for neuroanesthesia and neurointensive care in Galleria Hospital, Genoa, Italy. And before that, consultant in neuro and general intensive care, critical care department Alessandria Hospital, Italy, and pre-hospital emergency medical consultant, Imperia Emergency Hospital. And also she has worked as a specialty registrar in anesthesia and intensive care in San Martino University Hospital, Genoa. She is PhD in neuroscience and neurosonology, and her thesis for PhD was ultrasound-based non-invasive intracranial pressure from University of Genoa, Italy, which was supervised by Professor Marek Josinka. She was principal investigator of the multi-center study entitled Ventibrain, Guidelines for the Use of Ultrasonography in Intensive Care, Neuro-COVID, Center TBI Study, and Synapse ICU. She has 242 publications with an H index of 29 and citations of 2,966. Her education and training includes Idoneo al Bilatagiono Scientifica Nazionale Italiana in Neuroscience, Neurosonology, supervisor Professor Marek Josinka with the thesis topic ultrasound-based non-invasive intracranial pressure. She is a postdoc from University of Brussels, and she has got a certificate of training and certification and the Italian Society of Neurosonology. She is MD from Medical University of Genoa, Italy. She has worked as a specialist in anesthesia and intensive care and pain medicine in San Martino University Hospital, Genoa. She has done MA in pain management from the University of Milan, Italy. She has got a ECMO fellowship from ECMO Center, Pavia, Italy. And she has got a diploma in echocardiography from British Society of Echocardiography, Papworth Hospital, Cambridge, United Kingdom. She has also got a certificate for emergency medicine and pre-hospital setting from University of Genoa. Thank you.
Thank you, sir, for that very wonderful introduction. Without further ado, let us welcome Dr. Chiara to deliver the much anticipated oration.
To give a lecture on the ICU management of traumatic brain injury patients. And I would like to share with you the new results of the Center TBI studies, which have provided new insights on the development and on the study of this pathology. So we will start basically with some epidemiology, and then we will go through the management in the ICU, especially focusing on intracranial pressure, and then we will discuss the outcomes of this population. I have no conflict of interest for this talk. And this is one of the most important publications on the incidence of traumatic brain injury. As you can see, the annual incidence for 1,000 people is much heterogeneous across the world, with a higher incidence, especially in North America. And it depends, of course, on the region, and it depends, of course, on the type of brain injury, because if you look, for example, at the incidence of road traffic collisions, the incidence is much higher in low-income countries like in India or in Asia or in South America, etc. Obviously, the incidence also depends on sex and depends on the severity. This is the incidence of traumatic brain injury according to the different age, and this is a study regarding the systematic analysis of global burden, and we are talking here about moderate on the left and severe on the right traumatic brain injury by age and sex, and these are the population. As you can see, there is a higher incidence regarding both moderate and severe TBI regarding the male population here, especially in the early ages, and then when people get older, the incidence of female and male traumatic brain injury basically does not importantly change and becomes more similar and more heterogeneous. And as mentioned before, this is a very nice study published on Lancet Neurology last year, which basically describes the different types of traumatic brain injury and the causes of traumatic brain injury. Fall is now one of the major issues related to traumatic brain injury, and as you can see, it is more likely like in Europe and North Europe, especially in the United States, etc., whereas RTA with a medium or low HDI are more common in India or in Africa or in South America. And this means that the TBI population is basically changing, because if we see the results, if we see the data of some years ago regarding the TBI population, fundamentally the cause of TBI is importantly changed. A few years ago, the TBI population was mainly young and related to road traffic accident, and now the TBI population are mainly older people and are related to incidental falls. And this is related to all the factors that have been improved in terms of prevention of traumatic brain injuries, etc. In fact, this is exactly what I mentioned before. Until a few years ago, the major TBI patients were young, were male, were previously healthy, were patients who did a trauma with high-speed trauma and had a lot of extracranial lesion, and the major type of TBI was DAA, extradural contusions. In nowadays are mostly elderly. They mainly fall. They have a lot of comorbidities, and the problem is that most of them assume and have anticoagulants. Many of them do not have extracranial lesions, and for the majority of the cases, they have subdural hemorrhages. And this is exactly the picture of TBI patients. This is another very important study from 2021, and this is the study of the center TBI, including in total 21,000 of patients. And as you can see here, there are both high energy TBI in red and low energy TBI. And these are the admissions according to the location of the admission, so emergency department, admitted to the hospital, but in the ward and in the ICU. And as you can see, in the ICU, the characteristics of the patients are quite different compared to the others, especially for the GCS, especially for the abnormalities of the CTs, and especially for the higher energies of the impact, of course. And of course, these importantly influence also the outcome. But what I told you before, the fact that we now have a lot of elderly people and most of them are frail, you know that there is an important difference between being old and being frail. And this is a study which was performed by the group of Monza, published on Lancet Neurology last year, in which basically the goals was considered according to frailty scale. And what they found is that this is independent in reality from the age of the patients, but it depends on the frailty of the patient itself, which is related in small part to the age, but also and especially to the comorbidities and to the pre-hospital factors. And the center TBI study also found that there are a lot of differences in the management of these patients, even in the surgical management. This is an important study which basically was focused on the assessment of the type of surgery and the use of surgery or conservative treatment for acute subdural hematoma. And this is basically the incidence of early treatment of subdural hematoma. And as you can see here, there is a huge heterogeneity regarding the surgical treatment of these patients. There is a large heterogeneity. This is the more, so each one of these dots is a center of the center TBI study, and this is the more, which represents basically the difference in practice among different centers. And as you can see, there is a huge difference regarding the timing and aggressiveness on acute subdural hemorrhage here, There is also a high variability regarding the primary decompressive craniectomy. There is less variability regarding the early surgery regarding intracranial hemorrhage. But the important point is that the timing and the aggressiveness of surgery for traumatic acute subdural hematoma does not influence the outcome. So this means that basically guidelines are present, local practice is present, but probably it's not just about the surgical treatment that we need to take in consideration when we treat these patients, and it is the ICU treatment. And to better understand which is the right way to treat these patients, we have to do one step back, and we have basically to go back to the anatomy and the physiology. Because the brain is a particular organ in the body. The cranial cavity is made for 80% of brain, 10% of blood and CSF, and the normal intracranial pressure is below 15, let's say below 20-22 millimeters of mercury, and there are several mechanisms of compensation which allow to keep the ICP within certain level despite the presence of intracranial issues like intracranial hemorrhage or intracranial masses. And the increase of the raise of intracranial pressure causes a high number of pathophysiological issues. First of all, effect on cerebral hemodynamics with a collapse of bridged veins here, increased venous pressure, reduction of a CPP and of ischemia, and then it causes a direct pressure on the brain edema, which is related to an obstruction of the CSF flow and therefore brain herniation, which is the worst situation which can actually happen. And even when you do the first CT in your TBI patients, you can actually assess whether there is an exhausted volume reserve. And this is described by, for example, the presence of obliterated cortical sulci here, the presence of extradural hematoma in this case with edema compressing the ventricles and the basal cisterns, and the obliteration of the cisterna magna representing cerebral tonsillar herniation. So there are also other type of CTs which are clearly basically demonstrate an excellent volume buffering reserve, which is basically a situation like this when you have cortical sulci which are very visible, basal cisterns which are open, and open cisterna magna. And basically these patients are those who are less at risk of increased intracranial pressure. But the increase of intracranial pressure is also related to another factor, which is basically the fact that you are the fact that ICP is importantly related to the CPP, and CPP is very important for these patients because it is basically the driving force which causes and which gives blood and nutrients to the brain. And normally organ blood flow is a function of difference between arterial and venous pressure, and the CPP is basically the perfusion pressure that goes into a closed box. So basically it also depends not just on the mean arterial pressure, but it also depends on the pressure inside these blocks, which is basically the intracranial pressure. And there is a strict and important correlation between CPP and ICP, which is basically described by the vasodilatory cascade. In fact, if you have a reduction of a CPP because, I don't know, you have an episode of hypotension, this causes vasodilation, which can be caused by CPP itself, because when you have a reduction of CPP, the brain tends to keep constant the cerebral blood flow, and this is done through an effect of vasodilation. But vasodilation can cause increase of cerebral blood volume and increase of intracranial pressure, which further reduced the cerebral perfusion pressure. So this is basically called the vasodilatory cascade, which has to be taken in consideration every time we treat a patient. So when we have a patient with traumatic brain injury, the first thing that we need to do is to consider the ABCD approach, and one of the major factors to assess and to treat these patients is to protect the airway. In fact, up to 65% of brain injury patients may be hypoxemic, and these are very often hypoxemic, and hypoxemia is related to central nervous system factors for a loss mainly of the central drive, but it can also be related to extracranial issues like aspiration of secretions, chest trauma, fat embolism of long bones, etc. So in these patients, intubation has to be very, very aggressive because hypoxemia is very common and is an important cause of secondary brain damage. But also these patients have to be taken in consideration with ventilatory management because CO2 has to be importantly maintained. And this is just the first of a major consideration that is important for you. We don't have the time to go through all the factors of TBI, but I want to let you know that every time you have a TBI, you have initially a local inflammation, which then develops and causes a systemic effect in all the organs. So all the organs after TBI are basically affected, and the lung is one of the most affected. So pulmonary complications are very, very, very common. So after the intubation, so you are probably in the pre-hospital settings or in the emergency department, what you have to do to avoid the secondary brain injury is to maintain an appropriate CPP because of the reason that I showed you before, and then high attention should be paid to not increase the intracranial pressure. And there are really few very things simple that you can do, even if you are in the pre-hospital setting, like you can keep a patient with a neutral neck, because if you keep a patient on a lateral neck, you have an obstruction in the outflow of the venous flow. You can also reduce and avoid the use of tight ties, and you can avoid high inflation pressures. And then you can sedate and ventilate the patient appropriately in order to reduce the presence of secondary brain damage. And then when you arrive in the ICU, there you have to start to study the ICP behavior, and you have to study the type of brain damage at the end of TBI. And the first thing that you have to do in these cases is to call the neurosurgeon, because TBI is basically a multidisciplinary issue, and neurosurgeons are very important for its management because in the majority, not in the majority, in many cases, the presence of surgical lesions allow to reduce intracranial pressure, just removing the intracranial issue. This is a subdural hemorrhage, which is surgical. There are some borderline situations where you can discuss with a neurosurgeon whether it is surgical or not, but the removal of intracranial hematoma and blood must be the first question that you need to answer to yourself when you need to treat these patients. And then there are some even non-surgical lesions which can potentially become surgically, but at first instance cannot be surgical. And these have to be discussed anyway with the neurosurgery, because these still may need ICP monitoring and may need follow-up and eventually a further surgery. And then, as I mentioned, you have to study the intracranial pressure. So let's imagine that the patient has gone to the operating room to remove the subdural hematoma, or hasn't gone to the operating room and has put an intracranial pressure monitoring. Now he arrives to the ICU, and what you have to do is to avoid secondary brain damage, avoiding ICP increases. And ICP is not just a number, but it's a physiological component, and it's basically related to the waveform analysis. So when you put your ICP on your monitor, you just do not look at the number, but look at the waveform. And you will see that this is the normal waveform that is associated with ICP, and it is basically related to 3 different waves. The first one is the percussion wave. The second one is the tidal wave, and the third one is the dichrotic wave. The first one is the arterial component, so it mainly depends on the cardiac output and on the stroke volume. The second one depends importantly on the intracranial compliance, and the third one represents the aortic valve closure here in the dichrotic part. So what happens is that even just looking at the waveform, you can have an idea of what is happening in the brain. You can have an idea of how the waveform analysis changes, because if you have an altered compliance, an altered intracranial compliance, the P2, which is the tidal wave, increases importantly compared to the P1. And if you look at it before and after the loss of intracranial compliance, I think it will be very easy just looking at the waveform analysis to understand if the patient is having a problem. And the other thing that you need to look at are the pattern of intracranial pressure. So look at the trend, not just at the number in the moment you are looking at the patients. So you can have a pattern of low and stable intracranial pressure like this. So you are looking at the time in the last 60 minutes. You can look, for example, at the time, looking at this type of pattern, which is an elevated and stable ICP, and this is very worrying. Here, something has to be done, and actually something should have been done before, because you can't leave a patient like this for 2 hours with elevated intracranial pressure. Otherwise, this is what happens. This is basically a multimodal neuromonitoring tools, which is the ICM Plus that we use in Genova and which was developed in Cambridge. Here you have arterial blood pressure. Here you have the ICP, which importantly increased. It becomes refractory. And as I mentioned before, there is a strict relationship between ICP in white here and CPP, which is in pink here. ICP increases, CPP just drops, goes very, very low. There is an important loss of cerebral autoregulation, and this causes cerebral hypoperfusion, and these patients is a patient who will probably go in brain dead. And then there are some medium situations where the ICP does not remain intractably very high, but there are slow waves which are related to rapid changes of arterial blood pressure. And you can see very often these slow waves during the ICP monitoring. And you need to understand which is the meaning of these waves. These waves are the lumbar waves. You can have, for example, the waves called A, which have an amplitude higher than 50 millimeters of mercury. They last up to 20 millimeters, generally from 5 to 20 milliminutes, and they are mainly related to the changes in MAP. And these are very pathologic, and they importantly represent a loss of intracerebral compliance. And then you can have lumbar B waves, which have an amplitude of 50 millimeters of mercury, and they last up to 2 minutes and are pathologic, but often they don't require immediate treatment. And then there are the C wave, which have normally an amplitude of 20 millimeters of mercury and mainly depends on respiratory function, and these do not need any type of treatments. When we talk of treatments, we need to understand why we need to treat these patients. And the reason why we need to treat these patients is that if ICP goes up, this is importantly associated with a worse outcome. This is a very old study, but it was already well known that ICP instability, and in this case also outcome, was associated with worse outcome in patients with severe TBI. And here was the study which basically calculated the super famous 20 millimeters of mercury as most indicative of association with outcome. You know that when we talk about outcome, we always want level 1 evidence. In this case, we don't have a level 1 evidence because the only randomized controlled trial that was performed on the effect of ICP on outcome was this one. And this is the very famous study from Randall Chestnut, which was negative. But this study was had a lot of issues and was importantly criticized because it was underpowered from a statistical point of view, and most importantly, it did not compare the management of ICP, but only the monitoring. And the problem is that it's not about monitoring the patient, but it's about managing the patients. In fact, these patients, this study where patients were randomized in ICP monitoring and imaging clinical examination group did not have a protocol for ICP monitoring. And this means that these patients were just monitored, but the treatment targeted to on ICP was not performed. So a few years ago, we started the Synapse ICU study, which is an observational international prospective study published in Lancet Neurology in 2021. And this was an observational study conducted in 146 ICUs in 42 countries. And basically, we include patients from these ICUs with acute brain injury, with and without ICP monitoring. And we went to assess the characteristics and the use of ICP across these patients. And this is the more that you have already started to understand, so the variability across countries about the use of intracranial pressure monitoring, regardless of the severity of the patients, because this is adjusted for characteristics and for severity of the patients. And as you can see, there is a huge variability regarding the ICP monitoring type and use in this population across different countries. But what we also found in this study is that the effect on outcome of ICP monitoring and treatment is importantly statistically significant. There is a reduction in 6 months mortality and neurological outcome, less on neurological outcome in patients who were monitored and treated for intracranial pressure. So reduction, especially in mortality, especially in those patients who had at least one reactive pupil, which means especially in those patients who are more severe. And this was consistent for all the types of brain injury as sensitivity analysis, so for TBI, for subarachnoidal hemorrhage, and for intracranial hemorrhage. So the guidelines, what are telling us, these are the latest Brain Trauma Foundation guidelines, and these are telling us that for the management of TBI patients, it is recommended ICP monitoring to reduce in-hospital mortality and 2-week post-injury mortality. Despite this is a level 2 of evidence, so it's not very strong, this is a recommendation of Brain Trauma Foundation. But the other question is when to treat these patients, which is the threshold of ICP. As I mentioned before, initially there was a threshold which was the 20 millimeters of mercury. In the most recent guidelines, this threshold was moved to 22 millimeters of mercury. And this comes from unfortunately, one only retrospective single center study, which was a very good study, well performed, but still one single center study, whereas you can see here the chi-square for mortality and neurological outcome came the statistical analysis at the level of 22 millimeters of mercury. But what we are understanding now, what we know now mostly is that the problem is not about the number, the 20, the 22 of ECP, but it is about the dose. So it is basically the time which is spent above a certain threshold, which is 20, 22, whatever you want. But this is what the group of Leuven has very nicely demonstrated. In red, there are basically the patients with worse outcome. On the left, in adult patients, in the right, in children, so with a different threshold. But as you can see here is the millimeters, the values of ICP, and this is the duration of the insult. And as you can see here, what we learned from this study is that even small increases of ICP, like 25 millimeters of mercury, but for a very prolonged time, can be associated with worse outcome. And this means that we have to study the physiology, we have to study the waveform, we have to study the behavior over time of intracranial pressure. And then we have to treat our patients. And for the treatment of intracranial pressure, we have very simple algorithm. This is the most recent and most used algorithm, which is the Seattle algorithm. This algorithm was developed in 2019, and basically it includes the treatment of intracranial pressure as a staircase approach. So which goes from a tier T of treatment, which is just the basal treatment, to a tier 1, a tier 2, and a tier 3, where tier 3 are the very aggressive treatments which should be used and reserved only to severe intractable intracranial hypertension. In this case, here is a bit of regarding the dose. And when do we have to put the intracranial pressure monitoring? These are still the Brain Trauma Foundation guidelines from 2007. And these guidelines were quite clear because they basically suggested to put ICP monitoring in all salvageable patients with a severe TBI, so with a GCS between 3 and 8, and an abnormal CT, which was also well defined, plus in other clinical conditions. The problem is that in the latest TBI guidelines with a level 2 of evidence, basically the recommendation from the prior third edition are not supported by evidence meeting the current standard. So basically the indications in this case have been downgraded. It is true that basically we still consider the guidelines from 2007, but the newest guidelines really didn't help in making homogeneous the indication for intracranial pressure monitoring. And this is well demonstrated by this survey, where basically the responders were asked to basically to say which were the indications for intracranial pressure monitoring in their institutions. In the majority of cases, these followed the guidelines from 2007, so GCS below 8 and CT abnormalities, but look at the heterogeneity regarding the other types of indications, or in some cases with contusions, but a GCS of 9 to 12. In some cases, regardless the CT with a GCS below 8, or in the inability to assess the patients, or when there are extracranial or peripheral issues, etc. These are the results basically from the Synapse ICU study, where we also studied the practice of ICP monitoring. Location of ICP monitoring mainly in the operating theater, but also directly in the ICU, and in the majority of cases ICP monitoring is inserted by the neurosurgeons, and only in very few cases by the neurointensivist. And this is quite important because in some centers this is basically changing. And how do we monitor ICP? There are different methods to assess and to monitor ICP. One is the intraventricular catheter, which is the gold standard and also allows the CSF drainage. It is basically this system. It has anyway an infection risk which is around 6 to 11%. Otherwise, there are the intraparenchymal catheters with a strain gauge, which goes basically inside the parenchyma. Here the infection risk is very low, but it measures the local pressure and not the pressure inside the ventricles. There is also an intraparenchymal but fibre optic, which does not require the zeroing, and again the risk of infection is very, very low. It has the same issues of the previous one. It can be used, for example, in the compressed patients very often. And this is the Hutchinson triple bolt, which basically includes the bolt for ICP monitoring, the PbTO2 monitoring, and also the catheter for macrodialysis. And it allows a multimodal neuromonitoring tools. And these are again the results from the Synapse ICU study. In the majority of the cases, 60%, 59% of the patients, the catheter type is a parenchymal one, 36% intraventricular, and subdural and epidural are not used basically anymore. When are these catheters inserted? Of course, the more in the early phase it is, and the better it is, because of course brain damage and increased ICP are often occurs in the first hours and in the first day, and in fact in the 81% and 5% is within the first day from ICU admission, and very, very rarely after the third day. So we talked about insertion of invasive methods. Invasive methods are good, are accurate, and they are the gold standard, but they can also have some issues. They can have infections, they can have hemorrhagic risks. And these are some examples. To avoid these, there are several non-invasive ICP methods have been developed by several authors, and this is a nice summary regarding the fact that non-invasive ICP methods are basically are a wide range of numbers of tools, and these are radiological findings, MRI, ONSD, ultrasound, CT, MRI, fundoscopies, arterios, venous TCD, etc. And all these have pros and cons, but the types of non-invasive ICP methods which are mainly used in the neuro ICU are those that are based on the ultrasound, and this is related to the fact that these tools are very easy to be used, are quite are easy to be used, are non-invasive, can be done at the bedside, are repeatable, etc. And the main types of non-invasive ICP methods that are based on ultrasound are the arterials TCD, which have different formulas like PI and flow velocity diastolic formula, the ONSD and the venous transcranial Doppler, which are basically have different characteristics. And in this study, what we did was to take all the non-invasive methods that are based on ultrasound and compare them with invasive intracranial pressure. And what we found is that the most accurate was the ONSD and the venous TCD. The ONSD and the venous TCD found to be very accurate for the assessment of intracranial pressure, especially the optic nerve sheath diameter, and the combination of them improved even more the accuracy. So this suggests that the combination of different methods for non-invasive ICP monitoring can increase the accuracy. And among these, if I have to give you an advice in terms of type, and especially for the simplicity of a methodology, it is the optic nerve sheath diameter. This is a meta-analysis that we did a few years ago, which basically demonstrated an important accuracy of ONSD in the detection of intracranial pressure, and with an area under the curve, so with a sensitivity and specificity which is very high for this population. Now, for what I told you, the numbers are very good for non-invasive methods, so you might think that we can substitute them with the invasive ones in the clinical practice. And the message that I want to give you is that this should not be our type of clinical care. So there are a number of important limitations which are related to the non-invasive methods, which importantly preclude the fact that they can substitute invasive methods. It's true that they have many good points. They are safe, easily available, low cost, non-invasive, but they are not accurate enough to substitute the invasive methods. So do not use them in case there are the indications for invasive ICP. Going back to the invasive ICP, so this was just to tell you that the type of monitor that we have to use are invasive ICP, and it is on this type of monitoring that we have the guidelines to guide our treatment. And as I mentioned before, we have different tiers that have to be taken in consideration. And as basic measures, seems very simple, but in practice it might not be. As tier 0, what we have to do is to simply maintain the physiology. So if we are good general intensivist, we have done already the 80% of the work in treating brain injured patients. So the first thing that we need to do is to maintain an appropriate physiological status of the patients. With Fabio Tacconi, we had fun to create these acronyms because it's easy to be remembered. The GOST cap, so glycemia, hemoglobin, oxygen, sodium, temperature, comfort, arterial blood pressure, PCO2. If you take in consideration and you target appropriately these factors in brain injured patients, you have done really an important work. And if this doesn't work, then you have specific tiers for the management of intracranial pressure. The tier 1 is this one, and these are all the things that you can do if basic factors do not work. You can keep CPP 60 to 70, you can increase analgesia and sedation, you can maintain a PCO2 at not normal values, but a bit lower values, still in physiological range, but let's say 35, 38 millimeters of mercury. You can start some osmotic therapy, you can put a CSF drainage, you can use anti-seizure prophylaxis and consider EEG monitoring. But keep in mind that every time you use a tier, you have also to consider that every therapy that you use can increase the risk of complications. For example, the hyperosmotic agents, so mannitol and hypertonic saline are both considered very effective for reducing the cerebral edema, but we need to be careful about the side effect that they can have. They are generally used with in boluses, hypertonic saline with boluses of 100 millimeters of 5% of hypertonic saline of concentration. Mannitol, at least from 0.51 per kilograms, and they can be easily used and they work very well to reduce the intracranial edema and intracranial pressure. But be careful about the side effect. This is a sub-analysis that we did with a center TBI study, and we studied the incidence and the risk factors for acute kidney injury. And what we found is, first, again, high variability regarding the incidence of acute kidney injury, but especially the prediction, the ability of the factors which are predictive of acute kidney injury regarding the modifiable and non-modifiable factors. And if you see here, there are basically different factors which are associated with a risk of acute kidney injury in the ICU. Of course, a previous renal history, but also the occurrence of insulin-dependent diabetes. But look at this, osmotic therapy administration is associated with AKI and sodium above 150 during the first 3 days. So these agents work very well for cerebral edema, but take in consideration the side effects of each factors. And think the same, even when you go to the tier 2, you have as tier 2 different possibilities. Mild apocapnia, for example, neuromuscular paralysis, or the MAP challenge, and then setting the CPP according to the MAP challenge and to the autoregulatory status of the patients. What does it mean? This is basically the normal autoregulatory curve that we have studied in our books, and we know that there is a lower and the upper limit of autoregulation, a lower and upper limit of CPP, and within this range, the patients and the autoregulatory status of the patients works very nicely. And if you go below or above this value of CPP, this is associated with loss of autoregulation and therefore loss of outcome. What we have studied in our books is that this range is between 50 and 150 of CPP, and this is true in healthy patients, but in brain injured patients, this is basically the situation. So each type of brain injured patient has a different autoregulatory curve, has a different lower and higher limit of autoregulation, and this has to be taken in account, because if I keep a CPP of 60 in this patient, it can be fine because I am within the lower and upper limit, but it cannot be fine in this patient here. So this suggests that we have to individualize the autoregulatory status of the patients, and this is fundamental, because if we keep the pressure below or above the limits of autoregulation, we do a damage to a patient, because the patient is not protected anymore from hypotension or hypertension. And the guidelines are not super helpful in this. We are still in the fourth edition of the Brain Trauma Foundation, because they basically say to keep a CPP between 60 and 70 millimeters of mercury, and that the CPP threshold may depend on the patient's autoregulatory status. But this means that we need something to measure the autoregulatory status, and this means that we need to have something which is able to measure the cerebral blood flow. And we know that cerebral blood flow can be directly measured through a direct perfusion, so with PET, CT perfusion, CT, etc. But there are also non-invasive or invasive indirect methods to assess the perfusion, and one of these is in fact the intracranial pressure. So as autoregulation can be basically assessed in two ways, as test and as monitoring. This is how it is measured as monitoring. So if we know that autoregulation is preserved, if the cerebral blood flow is maintained constant, we can imagine that if the arterial blood pressure goes up and autoregulation works, the ICP remains constant or even is reduced because there is a better cerebral blood flow. If you have an impaired autoregulation, if arterial blood pressure goes up, ICP goes up. So this is exactly the principle. And this is the dynamic autoregulation. So you just let a software calculate the relationship between these two factors. But what the guidelines suggest is basically to do a test of static autoregulation. So I measure the arterial blood pressure at baseline and the ICP, and then I do a test. And if increasing the arterial blood pressure, the ICP goes up, it means that I'm not within the autoregulatory status of the patient. If it does not, the ICP is reduced or it does not change. And this is exactly the meaning of the MAP challenge suggested by the guidelines. So basically they tell us, do a MAP challenge, increase the CPP of 10 millimeters of mercury and see what happens to the ICP, and set the CPP according to the autoregulatory status of the patient. The other point is the hyperventilation. So there are different grades of target of CO2. Generally, reducing the CO2 can be useful for intracranial pressure because hyperventilation can reduce the cerebral blood volume. It causes vasoconstriction and reduction of the cerebral blood volume, which therefore reduce the intracranial pressure. But the problem is that it can also cause, because it causes vasoconstriction, can cause a reduction in cerebral oxygenation and cerebral blood flow. And this is what has been demonstrated by one of the different physiological studies. This is a study from 2002 from the group of Cambridge. Here you can see basically the area of cerebral blood flow below 20 millimeters of 100 grams per minute with a CO2 of 38 and with a CO2 of 25. Look how these are increased. So because of this and of other physiological studies, hyperventilation has been a bit discouraged. In reality, recent studies have demonstrated that if you keep a CO2 at values of 35, 38, or even 32, so not deep and for a short time, the cerebral metabolism is not affected by moderate hyperventilation, so it is safe and it is able to reduce importantly intracranial pressure. And we did a sub-analysis of a center TBI study, the center TBI study, and these are basically the results. Huge variability regarding the CO2 values across many different centers. Here you are. And these are the median values of CO2. As you can see, there is targets of CO2 importantly change. They go from 39 to 32 millimeters of mercury. And CO2 across the different centers is still used to control ICP. In fact, the targets are lower, are lowest are much lower in patients who have an ICP monitoring and who have refractory and elevated intracranial pressure. But the important message of this paper is that the fact that the center has a tendency to use hyperventilation does not affect the outcome. So probably we should reconsider the fact that hyperventilation, if used properly and with multimodal neuromonitoring, is not so dangerous as we thought initially. And then if the tier 2 do not work, we go to the tier 3. Well, obviously, I was talking about the targets of hyperventilation. So if you look at the guidelines, hyperventilation now is recommended only as rescue therapy, only in case of brain herniation. But here, so far, we talked about the targets for reducing ICP, so lower targets. And then as tier 3, so if all these factors do not work, we have the most aggressive factors which can affect intracranial pressure, which work very well on reducing ICP, which are the barbiturates, secondary decompressive craniectomy, hypothermia, active hypothermia. And as mentioned, these strategies, they work very well to reduce ICP. And because we said that time is brain, someone can ask, so why do we use them after using the previous one? So why don't we use them as soon as possible? And I like to do this simple example to explain you this. So if you arrive at home and you see a mouse in your home, you might get scared. Of course, I am a woman, so I get scared. And because I'm very scared, to make sure that I kill him, I might use the bomb, even if I have a mouse trap. But if I use the bomb, I can certainly kill the mouse, but also destroy my home and also kill myself. And it's a bit the same principle of the third 3 therapies. These are the evidence regarding hypothermia. This is the Eurotherm trial, which basically compared in 2015 patients who underwent hypothermia and then underwent control group, which basically compared hypothermia with the use of mannitol and hypertonic saline. And what was found here is that patients who received hypothermia had a worse outcome. But look where hypothermia was used basically at the stage 2 treatment of intracranial pressure, and not when intracranial pressure was refractory. This is the Polar study, which was negative, early prophylactic hypothermia in patients with severe traumatic brain injury. Patients before the treatment were randomized in prophylactic hypothermia and normothermia. And this trial was negative. So hypothermia should not be used initially as prophylaxis and should not be used in the initial phases, because we only get the side effects of hypothermia. But it should be used when other strategies have failed. Same story for example, decompressive craniectomy. This is the DECRA study, and this is a study where decompressive craniectomy was performed after 15 minutes of increased intracranial pressure. So very, very super early. And these are basically the results compared to standard of care. So ICP is much lower, okay? Even though in standard of care patients, ICP was still below 20 millimeters of mercury. And if you look at the results, the patients who underwent decompressive craniectomy had a worse outcome. Again, they were randomized very, very early. So Peter Hutchinson and the group of Cambridge did this trial on decompressive craniectomy after medical treatment, after all the therapies, and patients were randomized in surgical and barbiturates therapy. So after the stage 1, after the stage 2, after every type of treatment as tier 3 therapies. And in this case, they demonstrated that decompressed craniectomy improves the mortality at the expenses of neurological outcome, but in a long term, then neurological outcome can be improved. So it can, in any case, improve the mortality. Nowadays, there is a huge variability in the timing and the use of aggressive treatment. This is another more that you now like a lot. Huge variability across different centers and country, not only on the tier therapies in general, but on the type of tier 3 therapies. So some centers just use decompressive craniectomy, sometimes centers just use hypothermia, etc. But going back to the results of the Synapse ICU study, if you look at the model that we built on the outcome, when further adjusting for TIL, we found that the use of Tier 3 therapy, increasing the use of tier 3 therapies improves the outcome. So being aggressive, it seems to be worth it. And this is the sub-analysis specifically focusing on tier 3 therapies, which basically demonstrated the same, with the severity, at the same severity of brain injury, the use of aggressive treatment can eventually reduce mortality and 6 months unfavorable outcome. So the message is that tier 3 therapies have to be considered, but before arriving at tier 3 therapies, you have to use all the other instruments that you have in TBI, because otherwise you only take the side effect of tier 3 therapies and you can worsen the outcome. And when it's time to choose which is the tier 3 therapy to use, well, it's not that easy to decide this. It might depend on different, on the different type of brain injury. Of course, if you need surgery, you need the compressive craniectomy. Probably the compressive craniectomy is the best option in subarachnoidal hemorrhage or in contusion hematomia for perilesional edema. They respond quite well to hypothermia. For diffuse swelling, you can eventually consider barbiturates or also for DAI. But always keep in mind this scale. So you climb the staircase approach, but every time you do a stair, you have to take in consideration the aggressiveness and the side effects of the treatment that you're doing. And everything I told you is basically summarized in this very nice review from a Center TBI study, where exactly what I told you in a different graphical way is described. Now, just a few words about the outcomes after TBI. Outcomes after TBI depends really on a huge number of factors. It depends on the TBI itself, but it also depends on the healthcare system. You have seen the variability on social factors, biological factors, and psychological factors. So it's a huge, a complex point. And of course, it depends also on the velocity and on the trajectory of the patients. There are some patients which after admission go directly at home. There are some patients who go in the ICU and have a longer pathway. And of course, this importantly influences the 6 months outcome. In terms of 6 months outcome, we have different scales. Generally, the most used, and I have to say not very precise case, is the 6 months GOSE. So 4, 2, 3, and 1 are bad outcome. And as expected, you might see that basically according to the type of stratum, so emergency department, hospital, or ICU, the 6 months outcome is importantly influenced. Those with worse outcome are those in the ICU. You see that the GOSE 1, which is the mortality, is around the 20%, and it also depends on the duration of the stay in ICU, or even not in ICU, but even with a long stay, especially regarding the disability. And these are the basically representation of what I showed you, but just in a table. Again, even in this case, there is important variability regarding the outcome. And this is what I told you. It also depends on the healthcare system. It depends on the treatment. It depends on the protocol. But don't forget that we are taking consideration the GOSE, which is the most used, but there are a lot of other factors and scales which take in consideration also the quality of life, more fine issues like memory, the ability to go back to previous life, the ability to go back to work, etc. In general, you have to consider that nearly the 50% of patients, even with mild TBI, do not recover at the quality of life 6 months before the TBI, 6 months after injury. And the outcome in women is poorer compared to men. It's still not clear why. There is still little understanding regarding the individual differences in the recovery. And there are differences regarding the age specific, and there is a lot of research also regarding the long-term factors, the chronic TBI, or how it is called, which is importantly related to high risk of dementia. And this is basically one of the scales. The most used scales are the impact and the crash scales that are normally used to assess the outcome and the prognosis of the patients, and we all use them when the patient arrive in the ICU to understand how aggressive we should be, but don't forget that there are also a lot of other numbers. So, in conclusion, the TBI population is importantly changed. Different factors can be taken in consideration to assess and to reduce the risk of secondary brain damage. Monitoring and treating, especially ICP, can improve the outcome. The clinical approach of intracranial hypertension is based on a staircase approach, and each stair has potential risks to reduce ICP. Be careful about the second and third therapies, because this should be evaluated case by case, because they might be associated with a high risk of complications. Thank you for your attention, and if you have any questions, don't hesitate to contact me. Thank you very much.
Thank you, Dr. Shiara, for that thought-provoking oration. We are immensely grateful for your insights and wisdom with regard to monitoring and management in traumatic brain injury. We'll now proceed and open the floor for questions. I request Dr. Prasanna and Dr. Saurabh to kindly facilitate this segment. Over to you, sir.
Thank you. Thank you.
Yeah, thank you, Dr. Khaira. It was a nice and loose presentation, and I think everyone, including us our colleagues, have been benefited by this presentation. There are a few questions in the comment box, if I can read out for you. One is that can MCA flow pattern evaluation by TCD will help to check the effectiveness of hypertonic saline bolus dosing?
Thank you for this question. This is a challenging question because to answer, we need to think about how transcranial Doppler works. For sure, the assessment and the vision of the waveform of the flow velocity can help in understanding what happens in terms of cerebral blood flow and also on intracranial pressure. So when we do, for instance, transcranial Doppler in patients with increased intracranial pressure, you expect that you have a reduced flow velocities in the diastolic part, especially, and so you have a higher differential flow velocities, systolic and diastolic. So regarding this question, if you do an hypertonic saline bolus and you see that the waveform changes and the diastolic improves, and this means that the cerebral blood flow improves. In this sense, you obviously might get a sense of the efficacy of the treatment that you have done. Of course, you have to keep in mind the limitations of a transcranial Doppler, because transcranial Doppler looks at a flow velocity. So there are confounding factors. So if in the meantime there is also, for instance, a change in the CO2 or in the arterial blood pressure, you might think that what you are seeing is importantly affected by CO2 and arterial blood pressure. So you have to keep in mind that several things may change the flow velocities. But as long as you keep this fact constant, if you do a bolus of hypertonic saline or mannitol, you can actually use it to see if this improves the cerebral dynamics.
So, what will be your choice, whether it's optic nerve sheath diameter and I will say a pulsatility index of a transcranial Doppler for measuring the ICP non-invasively?
In general, if you look at the literature, the ONSD has a good positive and negative predictive value. The transcranial Doppler is able mainly to exclude the presence of intracranial hypertension. So in terms of accuracy, I trust more on ONSD, but I think that transcranial Doppler can really help to exclude when a patient has intracranial hypertension. Generally, I do both because both the techniques have some limitations, are ultrasound techniques. So we might have an inter-observer variability, it might be difficult to obtain an appropriate image. So generally, if you do both, and both instruments are telling you the same thing, in this case, I will feel safer in taking any decision. And regarding this is an important point because currently we are writing the guidelines for the management of TBI when invasive ICP is not available. So mainly for low-income countries where invasive methods are just not available. And among the recommendations, we will recommend that at least two non-invasive methods are need to say the same message in order to escalate the treatment of the tears. This is an important point because non-invasive methods are nice, are good, are bedside, are easy available. We all like doing ultrasound, but we really need to think about what we are seeing before making any decisions based on non-invasive methods.
Okay. And in the continuity, can you just put a light on venous TCD, as one of our viewers want to know about it?
So venous TCD is not very much used from intensivist. It mainly comes from the neurologist. I have learned it from a neurologist, in fact, and the training is much more complicated than the one regarding arterial transcranial Doppler. Basically, when you do that can be insonated, which are the Rosenthal vein and the stride sinus. These can be insonated, despite you have to keep in mind that in the 30% of the patients there are anatomical changes, so might not be reliable to be let's say to be used. Considering all these limitations, the good thing about venous TCD is that, in my opinion, if you think about the autoregulatory mechanisms, when ICP starts to increase, the first compartment which is affected is the venous compartment, because for the Moro law, you know, when you have an increase of a mass in the brain, you have to reduce the volume in another compartment. And the first volume which is affected is the venous one. So it is likely that the venous Doppler might be affected even before the arterial component and also the ONSD, which basically looks at the CSF. Okay. So, in my opinion, it's very interesting and very fascinating for this. There are not studies regarding the temporal changes of the venous versus arterial TCD, but it's something that I would like to explore because, from a pathophysiological point of view, I think it really makes sense.
Thank you.
Okay, so there are some video questions. Just let me post the videos. Yeah.
Many a times after the patient undergoes a decompressor craniectomy, the patient develops brain swelling. So how do we manage that?
Okay, so this is a very good question because there is a lot of discussion regarding whether after the compressive craniectomy you still need an ICP monitoring and how to consider this. We use it, the ICP monitoring, even after the compressive craniectomy, and in my opinion it makes sense because in any case you are measuring a pressure inside. You don't have a skull anymore, but despite this, is still the pressure within the brain parenchyma. Of course, the threshold should be reconsidered in this case. There is not in the literature a true new threshold for the decompressed patients. In general, what you have to consider is that you need to think about a lower threshold for treatment in a decompressed patients. How to treat it? Exactly in the same way you treat a patient with who is not decompressed. because if you have a pressure with the compressive craniectomy, well, generally, if the craniectomy is done properly, you should not have big issues with ICP, because I'm not a neurosurgeon, but we all know that the decompressive craniectomy needs to be large. It needs to be a proper decompressive craniectomy if we want to do a secondary decompressive craniectomy. If you do so, well, the frontotemporal parietal craniectomy is enough, in my opinion, to manage the ICP. But despite this, it happens in many cases, and it happens also in my unit, that we have to keep the sedation. We keep doing boluses of mannitol or hypertonic saline, and the weaning is very, very slow because of this issue. So the treatment concept to me do not change. It's just a bit considering the different thresholds. And of course, when you have a decompressed patient, use ultrasound as much as you can, because in this case you don't have the limitation of a bone. The window is fantastic, and it really seems like a CT scan. So in a decompressive craniectomy, you really don't have anymore all the limitations of the brain ultrasonography with the bone, and I really recommend it. It should really be considered the standard of care in decompressed people.
Just a question. I think Dr. Chiara, a very nice and wonderful presentation, very lucid. I would like to just ask a question like cerebral autoregulation has been discussed in great details, and we have been reading it since our starting the practice of neuroanesthesia and neurocritical care. So how to make it more user friendly and so that it is available at the bedside so that we can use it? Still, it is way far away from our day-to-day practice. We call it cerebral autology should be seen, but we are not able to see it. So any comments?
This is a wonderful question, because we have done a lot of studies, a lot of discussion about autoregulation. We all agree that it's super important, that it affects the outcome, but that at some point we stopped, because, okay, how do we use it in clinical practice? The first problem is that we don't have a level 1 of evidence that is affects outcome, despite observational studies are very strong. But the real problem is that if you think about all the studies regarding PRX or continuous monitoring of autoregulation, they are very nice, but they need a software. You can't escape from this. And also, having a software, you have to consider the limitation of a PRX. The bedside application of autoregulation are the static methods. So if you go at patient's bedside and you do a map challenge, or you do whatever you want to modify the arterial blood pressure, and then you think about the physiology, because if you have an increase of the arterial blood pressure and this results in a reduction of ICP, you have your answer. For that target of pressure, the patient is autoregulating properly. If the ICP goes up, you have your answer. The patient is not autoregulating because the flow goes together with the arterial blood pressure. Of course, it is not a quantification of autoregulation. It's a quality assessment of autoregulation, but can still be useful. Another test that you can use, if it's safe for the patient, is the carotid compression. This is a simple static method for autoregulation, which has been really standardized very well in terms of efficacy. Of course, you have to be careful, because compressing the carotid artery is not safe in all patients. So first do an echo to exclude any problems.
So there is a question that in the light of results of Synapse ICU study, should the BTF guidelines be changed regarding the ICU monitoring? Is there need to update the guidelines now, since these are the living guidelines? or do we have to still wait for some time or some more evidence?
Well, if we want a level 1 of evidence, the Synapse ACU won't change this because it is an observational study. So, despite it is a very large, well-conducted study, it's not a level 1 of evidence. However, it will for sure reinforce the strength of indication for ICP monitoring, because the effect on mortality is very, very clear.
Okay. So which is
Professor, okay,
yeah,
after this, I have some video questions. I'll post it. You just go ahead.
yeah. Actually, which is more important actually? Is it the ICP or is it the oxygenation? Because brain oxygenation is also
Well, I would say both. Of course, we are more used to use ICP, and for cerebral oxygenation, we probably need more a wider use. For PBTO2, we are waiting for 2 randomized control trials assessing the effect on outcome. The first trial has been published and was a negative trial. It was the OxyCT TC trial from the French group. So we are waiting for the other 2 trials to see what comes out. Despite this, I would say that, in my opinion, are both important because both are causes of secondary brain damage. An increase of the pressure within the brain, of course, can cause a worse outcome. But if you think about the physiology, a low quantity of oxygen in the brain for sure can affect the outcome, because the brain is importantly dependent on oxygen. So we probably need to learn at using both and reasoning for both. Because you can also have patients with normal ICP but low PBTO2, or the opposite. You can have bad PBTO2 with or good PBTO2 with relatively high ICP. So we really need to think about the physiology of the 2 instruments and treat both, in my opinion.
I have a little point on what Prasanna raised. PBTO2 oxygenation versus ICP. One of the criticism of this ICP monitoring is, with ICP monitoring we become reactive rather than proactive, because ICP can raise sometimes. ICP will go up at the later stages. Initially, there will be ischemia and ischemic changes, cerebral edema that will increase the ICP. So, with oxygenation monitoring like PBTO2, microdialysis, or those kind of things, we are in a much better position than to treat the changes going on inside the brain than waiting for the ICP to increase.
Yeah, I agree with you.
Professor Chiara,
My
very nice
question is,
presentation.
what is
Again,
the
I'll
role of
just
AI in
okay.
neuromonitoring? Thank you.
I'm
Good evening, Dr. Chiara. My question is, what is the role of AI in neuromonitoring? Thank you.
AI.
What is the
role of AI, artificial intelligence? AI.
Well, there is some work on it, especially for the prediction of changes in neuromonitoring. There are some work ongoing regarding the prediction of events of intracranial hypertension. So I'll tell you what I think about artificial intelligence. I personally think that it's something we need to explore, because obviously if we can improve and there is the possibility to have help from machines, it's absolutely fine. But we need to be very, very careful, because nothing can substitute the clinical assessment. We really need to be super careful when we see the results of a machine. For instance, if I see a patient where artificial intelligence is telling me that in 15 minutes he will have an episode of intracranial hypertension, for sure I will look carefully, I will assess carefully the patients, but I'm not sure I will do anything prophylactically, let's say, because at present I really need to be convinced a bit more about the efficacy in the clinical practice.
I have a question. Like, how long we wait before we switch from one tier of therapy? Sorry,
Thank you.
there you go.
Dr. Chiara, my question is, among all the non-invasive techniques to monitor ICP, which one would you choose and why? Thank you.
Yeah, he's already answered it.
So non-invasive ICP. So the concept is that each type of non-invasive methods has a different pathophysiological rationale behind it. So because of this, I don't have one preference because it really depends on what I want to look at. The ones that I generally use in my practice are the pupillometer with the MPI, are the transcranial Doppler, venous and arterial, and the ONSD. If I can, I use all of them because of the reasons that I've told you before. If I cannot, it depends. For instance, if I have a patient who has a risk of hydrocephalus, my first choice is the ONSD because ONSD looks basically at the pressure in the CSF. So from a pathophysiological point of view, I will choose ONSD. If I have a problem, an intracranial problem, which might mainly affect the optic nerves, in this case, maybe I will look more to the pupillometry because probably the first sign will be in the pupillometry. So I don't have a one choice, but if I have to choose one choice, I will think about the physiology. The other question was about how much do we wait?
Yes. How long will you wait before we switch from tier 1 to tier 2 therapy or tier 2 to tier 3 therapy?
Well, there is not in reality a definite timing because it really depends on the answer of the patient. I don't wait a lot if the ICP does not respond because I don't want my patients remains with a high ICP. Of course, we need to have clear in mind what we mean for high ICP and for how long. Because if my patient has a cough, for instance, and the ICP goes up, this is not an episode of increased intracranial pressure. You know what I mean? It's just what normally can happen. The problem is that if a patient is optimized, sedated, well treated, etc., has an ICP which goes up without any pathophysiological explanation rather than an intracranial issue. In this case, I treat quite immediately after 5-10 minutes of increased ICP. And then I follow the physiology of the patient. If the patient does not answer after the treatment, then I escalate because, of course, we know that the more time we spend with intracranial hypertension, the worse it is.
So I think this 5-10 minutes is a reasonable time rather than waiting for 15 minutes or 30 minutes or 1 hour.
For the increased ICP.
Yeah.
So if I am sure that the increase of ICP is not related to anything else, I am quite quick. So 5-10 minutes, I start the treatment. Then, of course, I give the time to the treatment to work. Let's say I do, for instance, mannitol or hypertonic saline. If they work quite quickly. So I don't wait 1 hour. I don't keep my patient 1 hour with increased ICP. I escalate because if you give a bolus, for instance, of mannitol or hypertonic saline, if they answer, they respond in very, very quickly.
I'd like to ask you, what is the role of decompressive craniectomy in refractory ICP? Do you advocate for an early DC? Thank you.
Exactly.
So I think that during the lecture, I hope that I clarified very well this point. The decompressive craniotomy can improve the mortality at the expenses of neurological outcome in some cases, but if you see the follow-up data of the study from Hutchinson, there is also a sign on an improvement of neurological status. So for sure, between the tier 3 therapies, if there is the indication, is the one of choice in my practice. But again, as we have seen, I don't use it in the early phases. First, I try always the medical treatment. And we have learned this from the big trials like the DECRA study and the study from the group of Cambridge, that if you do the decompressive craniectomy too early, you pay the price of being too aggressive when maybe there is no need, and you can manage ICP with medical treatment.
I was going through your studies and I found that mental bundle. Can you please say something about it?
Which study?
Not a study. I think it's a review. So mental bundle.
Mental bundle. The mantle. Okay. Sorry. That is an editorial that we wrote, and it is about how to protect the brain in terms of cerebral oxygenation. The concept of that editorial is that cerebral oxygenation is not just a number, but it is the result of very complex pathophysiological issues, and so there are many factors which can influence the cerebral oxygenation. And so when you see, for instance, an episode of cerebral desaturation, what you have to do is to think is not just about increasing the FiO2. The issue can be that you have a low systemic oxygenation. This is true, but it also can be because you have a low cerebral blood flow. So maybe the problem is the blood pressure. So you have to think about it. Or can be a problem of metabolism. So maybe the patient needs to be sedated more, or the patient is having a seizure. So the general concept of that paper is exactly this, to think about the multiple issues that can be related to cerebral desaturation.
So can we differentiate whether this problem is because of delivery of oxygen or because of inadequate utilization?
You
At
can,
the cellular level? Do you have means to?
Sorry? Do we have?
So how do you differentiate whether it is because it's a oxygen delivery problem or oxygen utilization problem?
It really depends on the clinical condition, because again, the concept is that you have an episode of cerebral desaturation. The first thing you do is to look at the hemodynamics. You do an arterial blood gases, you look at the HB, and you start to exclude the different factors. If you, for instance, see that the HB is low, you can think that the problem is about the HB. You do a map challenge and you see if the patient responds. You see the CO2. Sometimes you have a too low CO2, and this can affect importantly the cerebral oxygenation. So you consider the whole clinical pictures, and on the basis of this, you try to make some changes, and you see the responses on cerebral oxygenation.
Okay, so this.
So if there is an inadequate delivery, the causes are most of the time obvious, like hypotension or inadequate oxygenation, hypoxia, or it can be because of anemia. But how do we know inadequate utilization? Of course, we have to do that microdialysis study. Is there any other means of knowing inadequate utilization? Or
there is an echo, and I struggle to understand.
Dr. Kaira, Professor Pandya want to ask, how do you assess the oxygen utilization by the brain tissues? Means we have measures for oxygen delivery, but how do you exactly know whether that oxygen is utilized or not utilized? So at the utilization level, should you need more studies on metabolisms like microdialysis? That's his question.
Microdialysis can be the answer to this question for sure, because you have to study the metabolism. The metabolism can be studied at present only by this, and what we use in these cases is to couple the cerebral oxygenation values with VEG, which can give you a metabolic idea of what is happening in the brain. At present, at least in the unit where I work now, we don't have a microdialysis, for instance. I used to work with it in Cambridge. And at present, if you look also at the literature, to be honest, it's mainly related to research, to the research setting rather than in the clinical practice. But I think that the real answer on this is microdialysis. The other thing that you can do and that we do is to assess the arteriovenous gradient of oxygen. This can already give you a very good idea of the extraction of oxygen. So coupling this with the EEG and with the flow measured with transcranial Doppler, I think at the end you can have at least an idea of what is happening in terms of metabolism.
Yes. What is your choice on mannitol or hypertonic saline? What is your personal preference, or both, or combined?
So in terms of efficacy, there is not a difference. They both work very well. So it really depends on the clinical situation of a patient, because if, of course, you have a patient with hemodynamic instability, you need to be careful with mannitol because it is a diuretic. It's an osmotic diuretic. So the risk is that then the patient starts to have a very high urine output. This becomes hypovolemic and you have problems with the CPP. On the other hand, if you have a patient who is already hypernatremic, I would be careful in using the hypertonic saline. So what we do in practice is to use both. So for instance, if a patient has a peak of ICP, I give mannitol. If he has then another peak of ICP, I use hypertonic saline, and then I consider the clinical picture and the side effects of both.
No, if you give mannitol or hypertonic saline, are the changes in ONST are immediate? Like, how do you monitor them? Like,
Of the ONSD?
Yeah.
Yes, they are immediate. With ONSD, there are studies which demonstrate that you can see really real time the change of the ONSD.
What is the criteria in your institute to stop osmotic diuretics if you are not using ICP, invasive ICP monitoring? The problem of stopping osmotic diuretics, sometimes it's just surgeon's pressures, we are using it for quite a long period of time. They're afraid to stop it. Most of the time when there is a contusion on the other side of the brain, when the decompressive craniotomy has been done on the one side.
So I have to be honest that in my institution, if we don't have an ICP monitoring, it's very rare that we use the osmotic therapy, at least for many days. Because the concept, in my opinion, is that if you think that a patient would need many doses of mannitol, it's because the patient has a cerebral edema, and if a patient has cerebral edema, he needs an ICP monitoring. So this is the general concept. So generally, we don't use it if we don't have invasive ICP monitoring. If it happens, it's because, for instance, the patient has not indication for the invasive ICP. Let's say this happens mainly in spontaneous intracranial hemorrhage, not in trauma. So sometimes we use boluses of mannitol based on findings of non-invasive ICP, but not more than for 24 hours. Because otherwise, if we think we need more than 24 hours, we discuss with a neurosurgeon an invasive method.
Dr. Kair, I have a question. Coming to the first week, after the first week, and during the second week, when you are weaning the patient, traumatic brain injuries, some of these patients develop spontaneous hyperventilation. So should you address it? Because most of the times when you put a TCD and see, actually the flow is good, adequate diastolic flow is there. There's not much of reduced flow. The vasomotor, means cerebral vasoreactivity to carbon dioxide might be impaired. We don't know. But how do you address that? Should you control the ventilation, or should you accept the spontaneous hyperventilation which happens?
You mean when you stop the sedation and you are in the phase of weaning?
Yeah, weaning. Yeah.
Okay, so in this case, if you expect that, I would expect that in this phase the intracranial situation is more stable. So I generally allow the patient to wake up and to stabilize without resedating or forcing him to have more controlled ventilation. So I generally allow it, and then generally, at least what we see is that it happens, but it doesn't last for long. Then things in 24 hours gets actually better. If the patient hyperventilates a lot because he is agitated, in this case, I does treat him. We generally use dextrometin, but not specifically for the issue of hyperventilation, but to allow a correct weaning and a correct wake up without agitation.
In severe head injury, it might be a case of PSH, which is prolonging for next 3 to 4 weeks, and these patients in a
Yeah,
severe TBI,
PSH is the most common.
hyperventilating, hypertension, and tachycardia persisting for weeks in these patients. So in those patients, I generally allow. I don't know what the practice of other people.
Yeah.
Are you using any pharmacotherapy for improved outcomes? There was on trial in NEJM, I think amantadine or something, to improve outcome in traumatic brain injury patients. Are you routinely using any drugs, pharmacotherapy,
And if the follow-up
for
question is, are
improving
you
the
using?
cognitive function or recovery?
Yeah, and the follow-up question will be neurostimulants in TBI.
Okay.
Neurostim.
I think this will be the future. Because we basically over the last 20 years we have failed to find a magic neuroprotective agent, unfortunately. So research honestly now is shifting from trying to find a neuroprotective agent to try to improve recovery. There is a very nice study which was published on intensive care medicine about 1 year ago, which resulted in a huge discussion in the community. It was about the stimulation of the median nerve, which seemed to improve the recovery. On the basis of this, many interests has rise about the stimulation, and now we are applying for a grant with the idea to try acoustic stimulation in patients who are in vegetative status, because there are experimental evidence regarding the fact that an activation of the acoustic pathway can directly stimulate the locus ceruleus, which is the activator of the wake up, and the reticular structures. I think it's very fascinating, and to be honest, I think it's gonna work. But of course, I don't know it yet. But the pathophysiological mechanism really makes sense, and I'm really looking forward to start this pathway.
Okay. If there are no further questions,
Okay.
thank you. Thank you to all our experts for addressing the queries, and thanks for that engaging discussion. I would like to invite Dr. Keshav Goyal to deliver the end note to conclude today's memorable event.
Thank you very much. It is indeed a pleasure and privilege as a treasurer of Neurocritical Care Society of India to be delivering this end note. And the pleasure increases even more when hearing such a lucid and informative lecture from none other than Dr. Chiara Rubba, whose enthusiasm and research work is speaking a lot in the field of neurocritical care, not here, but globally. and she's really striving for success, which is basically the keynote for our society also. And Dr. Chiara will be troubling you a lot again in the future, as you have been already troubled a lot by us, by the society. So we keep and seek knowledge from you as and when required. So thank you very much again for the wonderful talk and the patiently you were taking the questions. Thank you very much. And at this
Thank
outset, yeah, thank you. And at this
I
outset,
sorry,
yes,
sorry. I'll go last.
please.
No, I just wanted really to thank you from the bottom of my heart. I know that your society is amazing and that you work very hard. And I really would like that our societies would work very much more together. And I hope that this will be just the beginning for collaboration among us, because I really learn a lot from you, and to me it's very important that we stick together from all over the world. So thank you so much for this opportunity.
Thank you.
Thank you.
Our enthusiasm is even more increased with these words of yours. And at this outset, I would like to thank our seniors, those who have been guiding us, Dr. Uma Maheshwar Rao sir, whose blessings are always with the society, with us, Professor B.J. Ramesh, Professor Anil Parak sir, those whose blessings and guidance has always been with us. And none other than Professor Mehir Pandya, who introduced you, and of course his guidance and blessings are always with us. Thank you, sir.
Thank you all. Thank you all for that. Thanks to the distinguished speaker, the participants, and attendees for making this event such a resounding success. This concludes the NCSI Presidential Oration on Traumatic Brain Injury, Evolution of Monitoring and Management from a Neurointensivist. Thank you very much.
Yeah.